welcome to this tutorial on CPAP, so continuous positive airway pressure. My name's Carmel, and I'm going to spend about half an hour or so talking through various components of this. I want to start by just mentioning that most of paediatricians' experience of using CPAP is in the field of neonatology and premature babies, and as you can see from the photographs here, there's a very simple piece of kit called bubble CPAP which can be used, and that's on the top left-hand photograph. And the benefits and advantage of this is that in fact it can be used also in the third world, and there are emerging studies being published of the use of bubble CPAP because it's low tech in third world countries, so Pakistan and in Africa, in the treatment of respiratory failure in children and not just premature neonates. So these are the areas that we're going to cover. Does it work in acute respiratory failure in children as well as neonates? I want to talk through a bit about the physiology and anatomy of breathing in young infants and children, and some of the physiology and how CPAP can help in both type 1 and type 2 acute respiratory failure. A little bit of a summary of some of the physiological benefits that have been shown, and then on a more practical note, something about the interfaces that are available, and also where we think we might be going with it in our. So we know that bronchitis is the most common condition for acute respiratory failure in childhood, and there have been some limited studies showing that there's a reduction in intubation in severe bronchiolitis. The only reputable randomized controlled trial done in Chile showed that a baseline of 62%, so 13 out of 21 infants with bronchiolitis who were treated with standard oxygen ended up having to be intubated, whereas this reduced to almost half, so 33%, so 6 out of 18 infants who were given CPAP, and this was a randomized controlled trial from 2 different centers in South America. So this is our kind of baseline data. It's in very small numbers, but this is all we've got. We'll go through some of this in more detail later. A study from the south coast of England showed over a 2-year period that 11 out of 51 infants who were treated with bronchiolitis CPAP were intubated, and similarly over a 6-year period in the early 2000s, 6 out of 61 infants were intubated following CPAP for bronchiolitis. And in our own institution, over a 5-year period, we showed in retrospective analysis that 148 infants treated with CPAP, there was a 5.4% intubation. And also overseas, that this was reduced from 37 to 7% with a 5-year period of 161 infants at the Royal Melbourne Children's Hospital in Australia. So some emerging evidence that there's the potential to reduce the need for mechanical ventilation by using CPAP in bronchiolitis. What I'd like to move on to now is to discuss some of the physiological reasons why particularly young infants have a higher risk of respiratory failure, and this is really down to the inherent properties, the relative instability, as you may wish to call it, of the developing respiratory system. And one of the main features is the kind of exaggerated elastic recoil. We often joke that babies bounce So the bounceability is to do with elastic recoil of their body and their tissues, and this is also true for the lungs, which then means that when you breathe out, the lung will tend to collapse more easily, and therefore airways tend to collapse more easily. And so not only are the internal airways affected by elastic recoil, but the chest wall, which is highly compliant, becomes more easily distorted and isn't always able to keep the lungs open. And the ribs themselves being softer means that the rib cage is more easily distorted, and you get the possibility of sternal recession, for example. And furthermore, there's evidence that there are relatively fewer fatigue-resistant units, particularly in the diaphragms of young infants compared to older children and adults. And as you can see in the diagram, that we do need some elastic force to prevent the lungs from collapsing. And that elastic recoil is what keeps your airways open when you breathe in. So the airways get pulled open as the lungs open up, but the converse is also true, that the airways reduce in diameter when you breathe out. There are some very specific anatomical characteristics in the young infant that makes the upper airway much more vulnerable to inflammation, to disease, to swelling, to obstruction, and other problems. And these are highlighted in these 9 points of difference between a young infant on the right and an older child or adult on the left. And I think it would be worth just pausing the video here for a little while so that you can really analyse and read these carefully and remember them. Not only are the upper airways affected, but the lower airways by being young and relatively immature. And a particular problem is that with smaller airways, the effect of edema or swelling is disproportionate if you compare to a slightly larger airway. And this diagram illustrates that. So we have an infant airway at the top left hand, 4 millimeter when it's normal, and an adult airway which is for example say 8 millimeters. And if we then apply a 1 millimeter edema to both these airways, you can see there's a disproportionate reduction in airway diameter in the small airway, such that the cross-sectional area is dropped by almost 75% compared to only 44% in the larger airway. And this means that the increase in resistance is 16-fold for an infant compared to 3-fold for an adult. And then you can understand how resistance is disproportionately increased by the same inflammation, i.e. a virus, for example, such as in bronchiolitis in an infant. And that's why infants get bronchiolitis and adults don't. Moving on to how in type 1, so hypoxic acute respiratory failure, the use of PEEP may help. Very simply put, you can see in the photographs of the lungs that the left-hand lung is deflated and the right-hand lung is relatively inflated. And by inflating any deflated or collapsed alveoli. This basically makes the lung act less stiff, and therefore the work of breathing required to inflate alveoli that are already inflated as opposed to collapsed is much, much improved. In a similar way that when you try and blow up a balloon, at first it's very difficult because of the properties of elastic recoil, and the same thing happens in the lungs. Once you've inflated a bit, it becomes much easier, and the same for the lungs. And by increasing the number of alveoli that are open, that allows more oxygen to be absorbed into the capillaries from these open alveoli. So by giving oxygen and keeping the alveoli open, you can treat hypoxia and hypoxemic respiratory failure with CPAP or PEEP. Now, in adult lungs with type 2 respiratory failure, where there's not just hypoxia but also hypercarbia or hypercapnia, one needs to increase minute volume, so either the respiratory rate or the tidal volume, in order to allow CO2 to be eliminated from the lungs. In young infants, the use of PEEP is enough to keep the airways open and patent, because we said already that there's increased elastic recoil in the lungs of infants, so we can exploit that property by giving PEEP and keeping the airways open, and that's nicely represented in the two pictograms. The left-hand one showing CO2 trying to get out of an alveolus in expiration, but the airway collapses and so there's not much movement, whereas on the right-hand one, with the use of PEEP, you keep the airways as well as the alveolus open. In an adult, it's more difficult to keep airways open because they'll be stiffer, whereas in young children, the elastic recoil being greater, we can keep those airways more open with relatively low pressures of PEEP. And so, unlike in adults, PEEP can also treat type 2 failure, and we often see that in bronchiolitis. When we look at the other benefits that have been shown by the use of CPAP in acute respiratory failure, particularly in bronchiolitis, we have the fact that the upper airway is maintained, and we've already seen the anatomy of why the upper airway is significantly more vulnerable and at risk. So the number of apneas can reduce and hypopneas. We've also already mentioned that we can increase tidal volume by keeping the airways open and reduce end-tidal CO2 by, in effect, inflating or blowing up the lungs a bit more, i.e. by increasing functional residual capacity. We can prevent atelectasis, and by preventing it, it reduces the work of breathing. We can also show that there's decreased respiratory muscle work, particularly in the diaphragm, and this would be visible because of a decrease in respiratory rate. There's a decrease in the need for the muscles, the respiratory muscles, to create auto-PEEP, and auto-PEEP is the mechanism by which you try and keep your airways open, so you grunt. And by stabilizing the chest wall with PEEP, for example, you can reduce also what Americans call retractions and we call recession. And finally, by reducing the work of breathing, we also reduce the amount of oxygen consumption associated with breathing. So it's an additional reason for benefiting from CPAP. Here are some of the different types of interfaces that are available to deliver CPAP to patients. In the top left-hand corner is a typical example of a helmet. And one of the great advantages of using a helmet is that it doesn't matter if you have an unusual shaped head or face or craniofacial abnormalities, you can deliver PEEP or CPAP through this contraption. And potentially it could be relatively well tolerated. In the middle of the top row of photographs you can see a full face mask, which is probably better tolerated, appears to be more comfortable than, for example, an oro nasal mask, which you can see an example of in the middle row on the right hand side, that young boy having an oro nasal mask. And on the top right hand you can see the kind of contraption that we commonly use in premature babies and infants, which interestingly has an extremely clever piece of contraption in it which reduces the amount of flow into the nose when the baby's breathing out, which for premature babies is particularly important, because you remember earlier we said that immature lungs have fewer diaphragm units which are resistant to fatigue, and that's particularly true for infants. And then so by giving them PEEP or CPAP you can increase the work of breathing out unless you reduce the flow a little bit, and that's exactly what these contraptions do. And it was the invention of these that allowed CPAP to really become successful in premature babies, because up until then the failure rate was actually very high. In the bottom rows you can see other contraptions, a nasal mask on the left, a different type of oronasal mask with what are called nasal buffers on the bottom with that gentleman, probably for sleep apnea I imagine, and a different type of nasal mask to try and make it more comfortable, perhaps for long-term ventilation, on the bottom right. If we look at the beneficial properties of various interfaces, so on the top row there's the 6 different types of interfaces: oronasal mask, total face mask, helmet, nasal mask or nasal prongs, and mouthpieces. And on the left hand column the property, and a dark black dot represents the ideal choice or the ideal property. A clear circle represents second choice, and an absence of any dot shows that this is not applicable to this particular interface. So for example, if we look at the fact that nasal masks, prongs and mouthpieces are less claustrophobic, and that an oronasal mask is the most claustrophobic because there's an absence of the circle there, and that it's easier to cough if you have a nasal mask or nasal prong. And of course we know coughing is going to be an issue with bronchitis. So there's pros and cons, and it can be therefore difficult to sometimes weigh up which particular interface is ideal for individual patients. But the key thing is to try and individualize it, so to have a number of different available interfaces. Finally, I'm going to just go through some of the UK-based evidence. So you remember we mentioned that on the south coast of England there was a study published looking at 51 infants between 2001 and 2007 and the rate of intubation in children being given CPAP of 4 to 6 centimetres of water, and they were achieving an intubation rate of 21%. In the north of England, in Hull, over a longer period of time, 61 infants treated with CPAP of again 4 to 6 centimetres of water, and they were able to suggest that this is a significant reduction in intubation. and CPAP being used on a ward, on a general paediatric ward. A feasibility study to see if it could be applied showed that in fact you could get intubation rates as low as 6.5%, 3 out of 46. And perhaps the advantages of using this on a ward is that there's no significant delay in applying it, so that you can treat earlier. And remember, one of the benefits is that you prevent atelectasis, and if you can prevent it, then clearly the work of breathing is going to stabilize, and the disease process is just going to kind of burn out over 2 to 3 days, and you can prevent intubation. And interestingly, in the Royal Melbourne Children's Hospital in Australia, they were able to show that with the introduction of high flow, that out of 57 infants, that they were able to reduce intubation from 23% before the introduction of high flow to 9% afterwards. And if we specifically look at what is the optimum CPAP and ask the question, is 4 to 6 centimetres of water enough, then the answer appears to be that actually for many infants 7 centimetres of water may be better. And here's 2 graphs showing the work of breathing associated with bronchiolitis. So the left hand y-axis shows something called PTPES /minute, which is pressure time product in the esophagus per minute, and this is a measure of the work of breathing from the respiratory muscles. And the x-axis shows what the level of work was when they were spontaneously breathing, and anything above the kind of dotted line is increased work of breathing. And if they were given CPAP of 4, that was reduced, but it wasn't until they were given CPAP of 7 that this was significantly reduced even further towards more normal, and that by increasing the CPAP to as high as 10, then in fact, although overall the work was reduced, it wasn't optimally reduced compared to 7. And the right-hand graph shows a similar function of PTP, but this time in the diaphragm, so offloading of the diaphragm by the use of CPAP of 7 compared to either 4 or 10. And as you know, on the back of that, we certainly used CPAP of between 5 and 7 centimetres of water, and we were judging how much to use by how well we reduced the increased work of breathing and the respiratory rate. And certainly before 2014, we were able to demonstrate a 5.4% intubation rate in 148 infants, probably the largest series reported. But of course, in our unit, after 2014, we started using a higher flow of heated, humidified, high-flow nasal cannula, up to 3 litres per kilo per minute. And this, for us, appeared to actually partly replace the need to escalate to CPAP. And with our experience increasing over sort of 3 to 4 years of using high flow, we were able to use it more early, and therefore we were able to maintain certain number of patients on just 2 litres per kilo per minute. So on the graph here, you can see the light blue line, which is the CPAP rate, peaking in 2013-14 winter and then dramatically dropping, whereas the dark blue line showing our use of high flow just continuing to increase, and the orange/red line, those patients the number of patients who needed 3 litres per kilo increasing, and the use of 2 litres per kilo kind of being stable really since 2012 to 2013. Suggesting that there's a group of patients in whom 2 litres per kilo, if given early enough, works fine, and that escalating to 3 litres per kilo per minute is required in some patients who previously we were giving CPAP to. So where next? Certainly in our unit, we're now exploring the idea of trying to use full face masks down to 3.5 kilogram children, which hasn't really been done very much before. You might remember from the table of interfaces that for acute respiratory failure, nasal masks not commonly used, but if the mouth is closed and the leak is reduced, and therefore it could become an appropriate modality, and we're exploring this in infants who like either to suck their thumb or a dummy, and see if we can use a nasal mask. And we think a nasal mask is more comfortable, therefore requires less sedation, and therefore enables perhaps a quicker recovery and earlier discharge. In addition, we've got extra work to do in our own unit, particularly around the equipment and making sure that everyone's familiar with the use of the ventilator, about making sure that all aspects of the care of the child on NIV being optimally addressed, and around also more universal use of SF ratio and understanding what it means and particularly how to use it and how to communicate it, for example, to our anaesthetic colleagues. And so there's a bit of work related around staff training with that. So on that note, I'm going to finish this presentation. Thank you very much for listening on this brief presentation about CPAP.